Today, I'd like to talk about the barriers to accepting new information. For instance, bias, prejudice, myth, the resistance to change, or disinterest, or inadequate education and experience, the discomfort or fear issues with opioids, addiction, regulatory agencies, respiratory depression, and system-wide attitudes about prescribing opioids. Einstein in 1955 said, "By age 18, we will have accumulated all the myths, biases, and prejudice to last a lifetime." Think about that. Let me define myth. Myth is a story, idea, or belief without basis in fact, handed down from generation to generation, perhaps intact or with facts distorted. Bias is a tendency to believe one side of a story without full consideration of the merits of both sides, usually considered to be unfair. Bias might be involved in LSU and Alabama football teams. Prejudice is preconceived opinion about an idea or concept that is not based on reason or actual experience. All of these present a barrier to knowledge based on exposure to misinformation or to ignorance. Infants and children learn from the tone of voice, opinions, attitudes, behaviors of parents, siblings, friends, and later from the media, especially TV, from schoolmates, and from video games. Myths, biases, and prejudices like this are difficult to overcome, especially when culture-based. What about overcoming myths, bias, and prejudice in a healthcare professional? A short answer might be, have an open mind, a willingness to learn, curiosity, learning new information based on fact, reason, logic, and evidence. Find a good teacher. Apply and use this new knowledge until it becomes the basis for your decisions in the work you do. Find a mentor to help you. Experience is the best teacher. The more, the better. Life is so different from the classroom. So let's talk about barriers to the adequate treatment of chronic pain that affects and influences healthcare professionals, with special attention to physicians and nurses. Healthcare professionals fall into three categories, as recently described by Dr. Charles von Gotten, the editor of the Journal of Palliative Medicine, in 2015. First, pioneers. Pioneers are actively curious, innovative, seekers of better ways to achieve a goal, champions. Secondly, prospectors, who are more cautious, conservative, picking and choosing. They are considered followers rather than leaders. And finally, settlers. Settlers are comfortably ensconced in doing what they do, and they are very slow to allow change. Let me define chronic pain for you. It is persistent pain, present for weeks, months, or years, present at least 12 hours daily, with an intensity of at least 5 on a 0 to 10 scale, where 0 is no pain and 10 is the worst imaginable pain. Types of pain: nociceptive, which is a word we don't use, we use somatic and visceral as nociceptive types pain. Neuropathic pain due to peripheral nerve or central nervous system injury. And the combination of the two we call complex chronic pain, a mix of types common in cancer and in traumatic injuries, where somatic, visceral, and neuropathic pain may coexist. What about education during training? Pain has been an often subject in the curriculum of medical schools. No discipline has embraced it as their own or would give up any of their share of the curriculum. Remember, chronic pain is now a disease, not just a symptom. In 4 years, and I'm speaking of until very recently, in 4 years, students got perhaps 3 hours of didactic pain lectures, no workshops, no training, and the house staff, interns, residents, fellows, learn about pain treatment from undereducated senior house staff and faculty. Therefore, myths about addiction and exaggerated fears about side effects of opioids are perpetuated. Fortunately, these deficiencies are being corrected. What about postgraduate education? Practitioners tend to retain the information they learn during their training. It became necessary to make CME mandatory for busy doctors to be exposed to new information in order to maintain accreditation and for reappointment to hospital staff. Pain lectures have done little so far to change the prescribing habits or elevate the standard of care. For many years, continuing medical education, CME courses, were controlled by drug companies who recruited physician lecturers that tended to favor the company's products. Better control of bias has been achieved by strict surveillance in the past 10 years. So, education and experience are linked. Lacking comprehensive knowledge about modern pain pathophysiology, actual treatments, techniques of treatment, it's a temptation to avoid treating pain. Without education, it's hard to get quality experience. The two are linked. A mentor or a colleague to consult formally and informally helps one to gain confidence. Delegate to a pain specialist when the pain problem is persistent or beyond your expertise. Let me describe one result of all these fears and insufficient education. 10 years ago, when I was a consultant and advisor on treating chronic pain at Ochsner Clinic, the medical administration, in an attempt to improve outpatient treatment of pain, attempted to delegate pain management first to the orthopedic service. They refused. They were too busy. Then to the primary care physicians. They refused. They weren't qualified. And so the administration began an interventional pain service instead, which did not really address the chronic pain population because these physicians in this program were anesthesiologists who performed interventional treatments and did not address chronic pain patients who required frequent office visits and pain prescriptions. The result now is the development of a palliative care program at Ochsner Clinic, where palliative physicians are beginning to control inpatient pain problems and are planning an outpatient program. They have the empathy and the training to address the problem more completely. What about fear of regulators? Deaths due to overdoses of opioids have quadrupled in the past 10 years. Prescription drugs account for half of these deaths, more than heroin plus cocaine. However, less than 20% of abusers receive them from doctors. They borrowed, bought, or stole them. The Drug Enforcement Administration, DEA, is studying excessive opioid prescribing. They have traditionally been most interested in drug diversion, but have taken on this new project. Medical boards, in general, support opioid prescribing if physicians use treatment guidelines and document properly. State narcotic agencies and prosecutors still need education about the empathic treatment of pain. Bias and prejudice very likely are their problem. The medical boards, the Federation of State Medical Boards, and also all state medical boards now approve and support the prescribing of opioids for treating pain. The guidelines define the minimum standards necessary to meet the standard of care. Considerable progress has been made in recent years in changing the attitude of the state boards. An entertaining, informative 60-minute video is available, Facing Fears, Pain, Medication, and End-of-Life Care, is on their website. Now let's consider the fear of addiction. The risk of addiction is overstated. The vast majority of patients with chronic pain are not addicts. The risk of being addicted is estimated at 1 to 3% in the general pain population when there is no history of prior substance abuse by the patient or in the family. 80% of addicts have inherited a genetic brain disorder, which is a lifelong problem. Normal pain patients follow the rules. Addicts bend and break the rules. This lifelong genetic brain disorder, the cause is a defect affecting the reward center in the brain by a lack of dopamine, an activating neurotransmitter that makes us normal. It makes us feel better. An addict is born with insufficient dopamine and seeks to feel better, to feel more normal. The tools used by addicts to increase their dopamine can be alcohol, nicotine, opioids, sex, pornography, etc. 80% of addicts inherit their addictive trait. After the boost subsides from the tool used to boost dopamine, the addict eventually craves that dopamine high compulsively, even though the activity or substance may be damaging to his or her health, relationships, job, or future. So how do we manage the problem with addiction? The best way is to screen for substance abuse in the patient and family when you do a history. Screen all patients and their families for whom opioids ought to be prescribed for chronic pain. If their pain is real, they deserve care. With a positive history, be more cautious, set stricter boundaries. If possible, entrust the opioid dosing to a reliable family member or partner. Remember, you are not causing addiction and suffering patients who have no abuse history in the patient and family. Next, let's consider opioids and respiratory depression. The worry that giving morphine to a patient will stop their breathing and kill them. First, understand that patients receiving opioids for chronic pain and or dyspnea, shortness of breath, can tolerate large opioid doses without serious respiratory depression when it is titrated appropriately and the dose is built up over time. Their respiratory center has developed tolerance to opioids. In contrast, opioid-naive patients, patients who have not received opioids recently, should be closely observed when they received opioids, as their respiratory center has not yet developed tolerance to opioids. Let me give you an example. Years ago, I was called to the emergency room in the middle of the night because one of my patients, an elderly lady, 90 years old, had gone into sudden acute heart failure, acute pulmonary edema. And she was rushed to the hospital. And in those days, a physician went to the emergency room. So I got there shortly after she did. On examination, she had pink froth coming from her mouth and nose. She was in acute respiratory distress. Her chest sounded like a washing machine. She was given morphine. She was given oxygen. She was propped up. She was given a diuretic, mercurochromate, which wouldn't work until the next day. But as she was observed over the next 30 to 45 minutes, there was a remarkable improvement in her situation. Her chest progressively cleared so that 45 minutes later, there was just a few moist crackles when one listened with a stethoscope. While I'm sitting in the treatment room next to her, writing my progress note with one hand and patting myself on the back with the other because I had done such a really good job, I glanced over at the patient and she was blue, breathing 4 times a minute. And she had not developed tolerance to opioids. And it was necessary in this emergency to inject intravenously Naline, not naloxone, Naline in those days. And within seconds, she was breathing comfortably. And I was very happy that I was available to relieve this emergency situation. So, in contrast, opioid-naive patients should be closely observed as their respiratory center has not yet developed tolerance to opioids. And let's try to overcome the fear of using opioids in the dying. Serious respiratory depression due to opioids is rare in patients being properly treated for chronic pain. If oversedation does occur, and it can occur, you don't know, this is a trial and error situation. If it does occur, sleepiness occurs first. Observe the patient closely, and if they're stable, you hold the opioid until awake, then resume at a lower dose or a different dosing interval, or change the opioid. Naloxone is very rarely needed with judicious opioid use. Evidence-based studies that indicate that careful opioid use in the dying does not hasten death, but allows them to live in comfort until they die. The benefit of opioids greatly outweighs the risk. In the last 3 years, 3 of the most prestigious organizations in medicine have had something to say about opioids. Here is what the Institute of Medicine said in 2014. Chronic pain should be recognized as a disease in its own right. It deserves correct, appropriate treatment rather than being untreated while clinicians try to identify its underlying cause. The American Thoracic Society and the American College of Physicians now approve the use of morphine and other opioids for managing chronic refractory dyspnea, or shortness of breath. This was published in 2013. And finally, the cardiologists have indicated that the use of opioids in advanced heart failure works by first dilating large blood vessels. It decreases dyspnea, it decreases oxygen consumption, and decreases sympathetic tone. Therefore, patients benefit because oxygen consumption is reduced and shortness of breath is reduced. Finally, in summary, recognize bias or prejudice in patients and families and in yourself. Become more open to the educational information presented. Seek more, be curious. Discuss with team members and colleagues any issues that concern or confuse you. Find a mentor to help guide you. And delegate to an expert or specialist when needed. Thank you.